Oh, for ID?
Hey, like, yeah, okay, I get alright. I'm getting like a heck no, and I'm getting like it was cool.
It was fine.
It was in between. In between.
In between? Okay. So I'm getting us all. So, okay. Well, you guys know some of these that you know how we roll. So you guys will get we will have a how the promote said AOC. So keep that way. Okay. So that being said, then for those that remember me, I'm Okafor. I'm one of the urgent care pharmacists over at Houston Medical Willowbrook. Click, got your jacket, of course. So that being said, we're going to talk about pulmonary artery hypertension. Now, just to give you guys a disclaimer, this is a very specialized disease state, very rare. You don't see it happen too often. I am for myself, guys are over 8 years old, probably see a patient have this maybe 8 times, I want to say. And those 8 times are more so of history and more so actually treating it actually from there. So with that, we're going to talk in detail about that. That way, by the time we're done with this presentation, that you guys will able to recognize it, able to manage it as a farm standpoint. I won't say you got to be specialists, but you guys will see a patient All right. All right. Now, for our objectives for this lecture today is to define, firstly, pulmonary hypertension, also known as PAH. You guys will see a lot of acronyms here because a lot of large and we're going to do different groups. Such as pulmonary hypertension, including PAH, will be our focus for today. And we're also going to discuss about the prevalence, the pathophysiology, and genetic causes of pulmonary artery hypertension, also known as PAH. And next, we go also to recognize signs and symptoms of PAH, including the clinical presentation and appropriate diagnostic criteria. And lastly, we're going to discuss in detail recommended treatment options for PAH, including side effect, drug interaction management, and monitoring. All right. So first is, what is pulmonary hypertension? So that is dealing with high blood pressure that specifically affects your pulmonary arteries, lungs in this case, as well as the right side of the heart. Know that the general cause is almost always due to increased pulmonary vasodilation or PVR. Know that PH is a major global health issue that affects all age groups. And know that the prevalence is higher in individuals aged 65, or in other words, our geriatric population, with pre-existing pulmonary and coronary issues. So example would be patients who may have COPD, for example, emphysema, as well as heart failure, which we're very much accustomed to already. Know that it does affect at least 1% of the global population as a whole. And know that PH specifically, this global prevalence is about 48 to 55 cases per million people. So that explains how rare this is on that end. Now, also know that right ventricular RV, in this case, heart failure, is a complication of PH. And as we talk about this, we're going to explain how to do that and how we prevent that from actually getting to that case. So it's usually mortality happening in these patients usually falls into that. Now, so these are actually the 5 groups that are associated with pulmonary hypertension. There are the subtypes of hypertension. So our first one is our PAH, or pulmonary artery hypertension. Our second group is our pulmonary hypertension associated with left heart disease, heart failure, for example. Group 3 is your pulmonary hypertension associated with lung disease and or hypoxia, which is COPD, like your example earlier. Group 4, which is your chronic thromboembolic pulmonary hypertension, also known as CTEP, which is more of a thromboembolic state that is completely managed on how we treat them using anticoagulation on that end. And lastly is our group 5, which is pulmonary hypertension with unclear or multifactorial mechanisms. However, see, there's a lot of groups right there. The only one we're focusing on is PAH. All right. So with our patho, we're going to talk about today for PAH. So what I want to point to real quick, I can hold this cursor here. All right. So right here, if you look right here for the pulmonary artery and the vascular obstruction, your point for known pulmonary arteries, right, everyone is usually like this. But with PAH, it looks like this. So you see, it's pretty much closed on that standpoint. Now, there's different mechanisms of how that happens, which goes into our pulmonary vasculopathy right here. So one way is due to like proliferation or fibrosis. So that artery is actually building cells that's causing it to close up like that. Then you have the vascular remodeling, where the arteries are most actually circling around the arteries and actually closing up on that standpoint, creating pressure, as well as the lesions that can come into this, what can cause the closing of those arteries, and also when the pressure being pulmonary hypertension, it's causing damage to those arteries, which cause a healing process, which also leads to the thrombosis formation, which will cause the closing of those arteries too. And of course, vasoconstriction, of course, and adverse does actually close it into as well. And that can lead to that vascular obstruction that I was talking about here too as well. And as you see right here, right heart failure, which I explained earlier, that's your complication in regards to PAH at that point. Which you will see the right ventricular remodeling, or if you think about back when heart failure, when you guys had it, it's more talking about the cardiac muscles remodeling itself because they're trying to have the pump better. So they were building extra muscle, which much people like to work out, have muscle skeletal, you don't want that for your heart. And that's what at least our heart failure point due to that increased pulmonary vascular resistance we're talking about too as well. As well as dysfunction happening in that right ventricle too. And right here for our current therapeutic targets, we'll talk more in detail when we get to the treatment section of the slides. So that will include areas such as your endothelial pathway, as well as your NO-SGC, CGMP pathway, as well as your prostacyclin pathway as well. And we'll talk about how each pathway will actually play a part in managing these patients and treating them as well. Alright, now for clinical presentation of PAH. So on the left figure right here, this actually talks about the symptoms, whereas the right talks about the signs on that point. So this is actually a little bit broad, but I'll tell you what's actually referred to for PAH at this point. So on the left figure, it goes from your early to late symptoms. Early symptoms, we'll start out seeing the dyspnea on exertion, as well as dyspnea when bending forward, which we call bendopnea. You'll see the fatigue and rapid exhaustion, which tends to happen with patients when they're just doing ordinary activity, or ordinary physical activity, which we'll talk about when we start classifying PAH too as well. Also the palpitation or heart racing on that point too as well. Hemoptysis, as well as your excess-induced abdominal distension and nausea. And then you also will see weight gain to the fluid retention. So you see about late, so now we're getting closer to that right heart failure symptoms we're talking about. And also syncope, which can happen during or shortly after physical exertion as well. Now, like there's a version that's happening with PAH in particular. That will actually include the external chest pain, that due to stress, as well as hoarseness as well, and shortness of breath, wheezing, and you see that too, also lower respiratory tract infections with pneumonia at that standpoint. So like, interesting thing is when you see these patients come to the hospital, if you look at their fast admissions, you see that you have an element of pneumonia every single time and you keep them the same symptoms at that point. That's actually a risk factor where you probably gotta look to see this patient also has PAH that's actually put them at risk for that. Now, on the second figure, which is on the right hand side here, so on the signs of PAH, you will definitely see cyanosis for sure. You also will see the systolic murmur and tricuspid regurgitation, as well as the diastolic murmur of your pulmonary regurgitation as well. And I'll say for right here, for the size point pointing towards outlining of the PAH, I will be concerned about this area because that's more something with the other groups. So we're not focusing on that. However, the part I want to point out to is the size of the right ventricular backward failure and size of the RV forward failure. So, size of backward failure, to give us an understanding between backward versus forward. So when we're thinking about backwards failure, we're talking about pulmonary congestion at this point. We're talking about fluid buildup that's coming in the arteries, push right back into the vasculature. So that's why you see example of the distended pulsating jugular veins, for that blood you pull right into the right side of the heart. You see that down distension too as well. You also see the ascites as well. The third space in the fluid in the abdomen was hepatomegaly associated with the ascites, and also you see pulmonary edema as well, showing us signs of backwards failure. However, when you see signs of RV forward failure, so that's where the right ventricle is not only to pump blood into to the pulmonary arteries, which gets to the lungs. So with that, if it's not able to pump blood to the arteries, well, guess what happens? Your lungs are going to oxygenate the blood to get to your left side, right? So when it does not, if they can't do that, that's when you're not only getting enough blood pumping to your left side heart to get to the rest of the body, but also you're not getting enough oxygen either. So that's when you start seeing as you distended, you also see the cyanosis, which we're talking about the blue lips as well as the blue fingertips, because there's oxygen there, so you guys will see that too as well. Well, showing signs of hypoxia from that end, as well as dizziness, as well as see a pale complexion, as well as cool extremities, as well as prolonged counter-reflow, which is all talking about hyperperfusion at that point. So that'll be a way to help explain you guys the difference between backwards and forward failure at that point.
Can you explain the difference in that?
Yeah, between backwards and forward failure? Yeah. So backwards is where pretty much that where the blood flow is coming from. Think of it this way. So everybody think about the heart, for example. So with that blood flow, what's happening is when it's getting through that jugular vein, but it's not able, but what happens is backing up because there's the pressure is so strong. So it's backing up back into the vasculature from the right artery. Yes. So with backing back into it, what's happening is you actually have a lot of fluid congestion coming back into it, leaking up from the vasculature. So when it's leaking in there, that's when you start seeing the pulmonary edema, because that fluid's getting back to that point. That's when you start seeing the fluid build up for the abdomen tube, for the ascites as well. And that's also where you also start seeing as well to like the jugular vein, because that fluid gets backed up back into your jugular vein. But you remember the normal flow is usually jugular vein goes right to the right artery. So that backup is causing that jugular vein to expand, which you'll see that for a backwards. So it's backwards, going backwards. But when you go forward, what's happening is that during how your blood flow works, it'll go right to your right atrium, go right to your right ventricle at that point. So what's happening in that right ventricle is not able to pump that blood into your pulmonary arteries and your lungs. So if it's not able to pump there, that leads to a problem where, one, you're not getting oxygenated blood to your left side of the heart, where it's blood's getting to the lungs. And then it also will lead to the fact that you're not getting enough blood volume to get the rest of the body. That's when you start seeing that hypoxia, because if you have blood flow, not much of it, but more of it is more deoxygenated blood. So that point, we start seeing the bluish lips, bluish fingertips too as well. Then there's like seeing the dizziness too as well as seeing like those cool extremities because you're not getting enough blood flow, and well as in that prolonged capillary failure. So that prolonged capillary so like if I'm pressing my fingertips, for example, you know how you see some blood flow come back pretty quickly. Well, in that situation for forward failure, you want it to be taking longer to get that happen. You have enough blood flow going because that right ventricle is not pumping hard enough to do so. I hope that helps explain it.
Yeah.
Good. All right, cool. I'll make sure you guys understand part. So when we get into the medications, that y'all see, I see how this works. At that point. Okay, so this is actually the WHO classification for PAH. and it's broken down to 4 different classes. And this would be a hint, a good way to know this too as well, because this actually will explain like the different classes and how we, based on FC class or functional class, that each PAH patient will belong to, and that will determine what kind of treatment we'll give them to us. So our class 1 will be patients with PAH who not limit physical activity or results in symptoms of dyspnea. So these patients are the ones who are pretty much asymptomatic. They have pulmonary hypertension, but they don't walk around like you and me without any issues at that point. And then you have your class 2, which is your patient with PAH with slight limitation in physical activity, but they are comfortable at rest. And they usually have those symptoms such as dyspnea, fatigue as well, the chest pain, or the near syncope during usually happens during the ordinary physical activity. So a good way we talk about example is going from the couch to the bathroom as an ordinary physical activity for anybody. So your class, think of this, we can use that as an example to help you guys understand that. So class 1, the patient is able to move from their couch, go to the bathroom without any issues, but they still have pulmonary hypertension based off what they saw. Then your class 2, same scenario. When they get up from their couch and go to the bathroom, they do feel a little bit tired, but they still make it without much difficulty at that point. And the tired can be the fatigue, or they may feel a little short of breath on that standpoint as well, or you feel a little bit of chest pressure just going to the bathroom. But it's not a way; it's very limited. But they're coming at rest too. They don't have any issues or symptoms on that point. However, when you get to class 3, so class 3 is where we're talking about the same thing. They go over the couch, going to the bathroom as well. But this time, as they're getting up, they really start feeling weight. They start feeling short of breath. They start being pretty tired. Where there's some difficulty trying to get there from the couch to the bathroom at that point. So at that point, it's more severe at that point. But they're still comfortable at rest though. Then lastly, you have your group 4, your class 4 or your FC4. Now this situation is where they can't get up the couch. So they can't get up the couch, they can't get to the back at that point without feeling any type of symptom, and it's pretty severe. And they're all unable to complete that activity at all. And even when they're resting, they're still having that same symptoms as well. So it's 24/7 pretty much. And unfortunately, these patients with class 4 are the ones who also have right heart failure too as well. Hence the reason why they can't really move around as much. So with these patients, even with any type of physical activity, will cause some level of symptoms that will happen. So unfortunately, these are more so your patients who are at the end stage of this disease at this point. Okay, so this is actually our diagnostic test that you use for PAH. Okay, for you guys, this is more so of we're pharmacists, not physicians, so we're not going to be diagnosing anybody. But it'd be good for you guys to understand it too, so when y'all see that, y'all know where it was coming from. So first we have our echo, which can be done, as inpatient or outpatient. And this is where you usually detect or monitor for that right particular function to see that pulmonary overload if it's there, as well as calculating your mean pulmonary arterial pressure or your impact, which is caused by PAH at that point. And that'll be a part of that diagnostic criteria we'll talk about in the next slide. Next, we also have our EKG, which is used to detect that RV hypertrophy as well as the RV strain as well. Which the RV strain you see because of that right heart failure at that point too as well, so that will detect that. We also have our 6-minute walk test, also known as 6MWT, which is used to measure exercise capacity when walking at a normal pace. So that's why I was using the trip to the couch for the bathroom example, because it's a little more mild, but that's a good way to explain what I said from layman's terms. So this test is actually not just used for PAH, but used for other patients too as well. So a good example is like, for example, for a COPD patient that came in with CV exacerbation, and we find out in the hospital they need oxygen to go home on that. Well, usually for us to make sure they need oxygen, we should do this test just to make sure and see if they actually qualify for it too. So like this is actually the pretty expensive. It can be done inpatient, outpatient as well. And this will be a quick understanding of how well they tolerate doing a normal pace at that time before they start feeling the symptoms, so that shortness of breath or the fatigue at that standpoint too as well. Note that the therapeutic goal in PAH is at least 380 to 440 meters in 6 minutes too as well. So that's when we'll look at when they usually evaluate the patient and also monitor as far as improvement. Then we have some genetics. Know that the presence of the BEMPR2 gene has a mutation in that gene. This leads to a 20% lifetime risk in developing PAH. And the way how we want you to monitor for that for these patients is to pretty much do a yearly echo for the ones who are asymptomatic and for possible carriers. So an example of this being like, let's say a mother of 3, and she got diagnosed with PAH at this point at the clinic. Their next step will be to actually start testing the children. So they're going to see we'll test her and see if this is actually was genetic at this point. And if it was, now they're going to test the kids too. And the kids still have to carry it, but they have no symptoms. Well, those kids also going to start getting echoes every year, just to monitor closely, because the disease today is all about the progression at that point. And the earlier you catch it, the better. And also to our competitors too, the EKG can be done inpatient or outpatient as well, along with your Smith wall test and your echo. Alright, now we have our pulmonary function test and your arterial blood gas, or ABG. Know that your PFTs, in other words, is used to detect your low blood diffusion capacity for carbon monoxide, which is your DLCO. So, I'm pretty sure, how many of you guys know what DLCO is? Alright, I think that you guys don't know yet. Okay, I'll explain to you guys. So, DLCO is pretty much measuring how much oxygen the lungs are able to translate into the blood. So the higher the better. That means that your lungs are able to produce oxygen to the bloodstream that begins to the oxygen rest of the organs in the body. So usually for PAH, it's usually normal to slightly low, which is 50 to 74%. And normal DLCO is usually greater than 75. Then you also have your ABGs, which detect your PaO2, which is your partial pressure of arterial oxygen. And it's usually normal or slightly low as well, which is about 75 to 89 around that range. Normal PaO2 is usually between 80 to 100%. Sorry, 80 and 100, sorry. So, physical signs of low readings, which include shallow breathing, as well as slow breathing too as well. So if you start, and this was seen on a patient, let's say they actually had a DLCO of like 55. Alright, we'll see that with their breathing on step or with the shallow. They also definitely will see a shortness of breath too as well. So you can see that from a clinical standpoint. And then we also have our right heart catheterization, our right heart cath. This is actually the gold standard in diagnosing and classifying PAH. So with that, know that an MPAP of greater than 20, as well as a pulmonary capillary wedge pressure, PCWP, of 15 or less at rest, generally is indicative of PAH. So like with PCWP, I will say with this slide, and particularly with these 3 tests, these tests you kind of want to see more so unless you're more into the internal medicine side and more so really into critical care at that point. That's why it's kind of maybe a little bit foreign on that end. So with the PCWP, that was measuring how measuring pretty much the pressure that's coming from the left atrium of the heart at that point. So if let's say your normal is between 4 to 12. Now for example, let's say it was less than 4, that means they're not getting much blood flow, which can lead to hypovolemia, which usually fluid are being used at that point to help manage that. But these patients were not with pulmonary hypertension were not concerned about hypovolemia because that's not the case for them. However, if it actually was greater than 15, at that point, what's telling us is that pressure is actually a compensatory mechanism for your left ventricle, because what's happening is that your left ventricle is failing because it's not able to pump the blood flow into the rest of the body. So it's failing. What's your body normally do? Compensate. It'll just try to fix it on its own. So what happens is that pressure that PCWP, it'll actually increase because now the right side is trying to help the left side out. So now pumping extra blood through the lungs into the left ventricle to help it to pump better. But what's happening is that it's not helping. So with all that extra volume, that causes that leakage to the lungs, which causes that pulmonary edema too as well. So like you see how it's starting to look like heart failure right now. We're talking about. So that's what usually happens in that case too. So that's why it's important to measure these two, because that will tell us what type of disease we're dealing with. In this case, for PAH. Do you guys have any questions about that process?
No.
Good. Only ask because depending on how your cardiology lecture is pathos is extremely important on that point. So let me make sure you guys understand why we're doing these medications at this point, so you guys know how we're taking care of the patient on that. Alright. Now we also have your x-ray that we use for diagnostic purposes. And I'll say just pay attention more so to here for the signs of PAH and abnormalities. Know that patients with PAH usually have abnormal findings such as the right heart and pulmonary artery enlargement. That's pretty much all you guys already know, need to be aware about as far as for PAH at that point. However, know that normal X-ray does not exclude the patient from actually having PAH. As a matter of fact, with an X-ray, you usually see this with more so patients who are actually more class 4 or maybe having maybe also showing signs of right heart failure, where it can be identified simply through an X-ray, doing a more basic imaging. Okay, now we go to treatment now. Alright, so you guys are familiar, as you do. I was like, before we start talking about treatment, I also want to know what is my role as a pharmacist in this disease? So, firstly, one role as a pharmacist that you guys to be aware about, and I'll actually start this slide because this will be helping you get a better understanding how to answer our questions too as well. And this is where the evaluation of PAH. So what I mean by that is to see which type of PAH does this patient belong to. And that actually will help us to identify indication and guide therapy based on the rational use. So a small example of this is doing a basic hypertension for a patient who has been diagnosed with PAH, to see if they can actually use calcium blockers based off that result of that test. So this is actually very important, because if we don't know what we're treating for, how can we guide therapy on that end? It's not something about safety, also got to measure efficacy too as well. Now, also know that there's currently no cure for PAH. Now, the current treatments are just to slow down disease progression, as well as improving the patient's quality of life. Which is actually the sad part about this disease, is that we're just trying to slow down the progression as much as we can, even halt it if we can, as well as make sure the quality of life is good too as well. Now, example, there's a I'll get to as well is knowledge of how to manage drug-induced PAH versus idiopathic or hetero-PAH, which I'll explain to you guys an example of that in our next few slides. Now, of course, I'll be remiss if we don't talk about, we'll make sure that the medication is a favorable side effect profile based on the patient. Drug-to-drug as well as drug-disease interactions are very important too as well. And you guys see here, I put in red with exclamation marks here. Medication compliance is huge. Now, the reason why I say that is because that actually will greatly contribute to their PAH improvement, as well as slowing disease progression, as well as improving those symptoms, as well as improving their exercise capacity. So the way I can approach this way is, like if they're missing doses for unknown reasons on that point, or they can't afford it, which we'll talk about next. What's happening is now that disease starts to progress, so they start seeing more of those symptoms at that point, and then start to bump it down from, let's say they were a FC2 or a functional class 2, now they're going down to 3, then they're going to 4, all because they're not taking their medications. So as pharmacists, compliance is key for them too as well. Now, we'll also put in red, cost, and cost, period. Reason why for that is because these medications are very expensive. I'm talking I'll say with the ERAs we'll talk about later on, they're about, I want to say this for a 30 supply, they're a couple $1,000s on its own. And with those, you usually have your copay cards, of course, insurance is very important, unfortunately too as well. So with that, even with those copay cards, it's still gonna be pretty expensive. You have those patient assistance programs where they will pay for it on their own, but it usually only lasts for a year. So these patients don't have PAH for the rest of their life. So it's a very costly disease in this thing too as well. And that will also contribute to medication compliance as well, as I mentioned earlier. The good news is, and this is why that basal reactive testing was important, calcium channel blockers are currently your most affordable medication class. Now, know that too as well that for the cost standpoint, is that they also really affect mortality and morbidity. So let's go back to what I was talking about with the compliance. If not compliant, mortality goes up, morbidity goes up too as well, quality of life goes down, and so forth.
So even though that CCBs are the most affordable, are they the best? Are they considered the best to treat the patient, or just more for affordability?
So from an affordability standpoint, I'll put it this way, I think as a pharmacist, for me, if I'm looking at a patient who came with PAH as a diagnosis, and we're trying to measure therapy in the hospital setting, you just initiate from that standpoint. My first thought says what kind of measure will we give to them is actually compliant for them. And when compliant, I'm talking about is the cyber profile safe for them? First off, is it gonna work for them for rational use? And then lastly too as well is will they be able to afford it? Because I had to think about not just for a month, like a revision step, I gotta think about the rest of their life. So if they only use calcium blockers, by all means, I'm going to shoot them first. Now, also depending on what type of functional class they belong to, I may not be able to use them based off what they place onto based off the diagnosis. So that's another thing I had to look into as well. So if we caught it early, and they had to be a candidate for calcium blockers, I'm going to shoot that first. And then from there you have, I want to say the other group would be your PDE5 inhibitors, which are a little more affordable compared to the other agents, but they're still cost quite a bit of money. Because remember, they're doing things every single month for the rest of their life. It's not like they're just getting antibiotics for a couple of weeks and that's it. So, but answer your question though, is more. I think for the standpoint of rationale, think about a side effect profile. Once I check those two off, and so next thing, can they afford it? Because all these three things will affect their compliance. And then of course, once I do that, you already know pharmacists will be educating too as well. That's gonna be another thing to help wrap everything up though. So that's kind of like quick and dirty from this slide here of what I was what you guys think about as a pharmacist to as well look at these patients. And really, this is kind of like how you want to think for any patient you look at. Because then they also want patients to be compliant. And if they're not compliant, what's the point of actually recommend you treat them with?
Excuse me, sir. Is it all types of calcium channel blockers that you can use, or is it specific to non-selective or selective?
So, I'm glad you asked that question. That's what we're going to talk about when we get into calcium blockers. There are only 3 agents in that class that we use.
Okay.
That's based off the studies that have been done for this disease state. But I'm glad you asked that. We'll talk about that in more detail for sure. Alright, so PAH is usually broken down as three different types. That includes idiopathic, means you don't know where it came from, it just happened. We'll also have your heritable or HPAH, which is pretty much the genetic from that standpoint, which is we were talking about earlier about that gene mutation, which is where that falls into. And also have your drug toxin induced, which is your DTPAH as well, which is drug induced. Know that IPAH as well as your HPAH require the same guideline directed management. However, while DTPAH is a different treatment approach. This kind of go back to that evaluation of how we manage that patient before we actually will start therapy. Now I know that even if we do all the right thing for this patient, we did everything we did as a pharmacist, everyone on the whole team does the right thing on the patient is compliant, and with the best treatments that we have, unfortunately the 5 years survival after PAH diagnosis is around 14.8%, which is, if you put this standpoint, completely other numbers. Like how I said about earlier in the presentation, like 40 to 55 patient cases per million people. So I should make it more personal. Think of it this way. I've seen 3 patients this year that actually had PAH. So out of those 3 patients, 1, 2 of them may not make it in the next 5 years. That's even us giving their best shot. We did everything we're supposed to do. We took care of them as much as we possibly can. They may not make that. So that's actually a very somber thought to think about. Well, unfortunately, it does happen. I had a patient actually pass away due to that reason for that standpoint. And actually, matter of fact, that bitch, rest in peace. She actually passed away due to cost. And what made it worse, for her situation was that she also didn't have papers either. So she didn't have insurance. So with that limited what we used to treat her with. And unfortunately, when we tried to treat her, it became a point of what she can afford and not what will help her. Because if it was more so what can help her, she would probably be still alive right now, but because she didn't have the money and much of the resources that we had to help her, that was enough, and unfortunately she didn't make it. So with that, this is why I say this disease is very specialized, but it's also not one of these diseases that people will live long with this. So that's why for us there's a lot of room for us to really help these patients out from ahead. So know that the current guidelines are used right now to treat these patients and we give them their best shot. And you break these different drug classes such as our prostacyclin pathway agonists, also known as your PRAs, your prostacyclin analogs, known as PAs, your endothelin receptor agonists, also known as ERAs, as well as our phosphodiesterase, our PDE5 inhibitors, and our calcium channel blockers, or CCBs. Now, so the next slide, that check mark, what you guys know. So with that, after initiation of therapy, know that patients usually are followed at 6 weeks, then every 3 months for monitoring cost, efficacy, and safety. Now, how we actually would treat these patients from a approach standpoint is that we will actually increase the dose, or we change the frequency of current medication. and or adding an addition of a second or third medication can be done during each follow-up visit or hospitalization at point. Now, knowing that optimizing improvement of exercise capacity, symptoms, functional class deterioration, so going from FC2 to 3 on the subtypes at that point, showing the degree to try to slow that down and halt it, and also slowing disease progression as well. Know that transitioning from one medication to another and adjusting the current regimen, like just the dosage or the frequency, due to the average best, can be done to improve their safety as well as to maintain their efficacy for that same medication. Now, also too, I'll say that mark of a hemodynamic improvement is patient achieving an impact less than 30, as well as a pulmonary vascular resistance or PVR of less than 4 units, also the WU. Alright, so our first approach we'll talk about is our DTPAH. So management, of course, is drug induced. All we're going to do is stop the offending agent, right? So that would result in our showing a full reversal of that PAH or a partial reversal once that diagnosis is made. Now, even if we stop that offending agent, we still watch that patient closely over 3 or 4 months, usually by follow-up visits, and evaluate if PAH directed therapy is warranted. Now, this only applies to patients who fall into the fall with mild PAH or the lowest profile, which is pretty much your FC1 for the WHO classification. So if they're FC1 on that end, and it was drug-induced PAH, and we stop that agent, we just watch them for the next we'll end up watching them over 3 or 4 months to see, okay, did they fully improve? Was it a full reversal? If it's full reversal, you want to need your medications. But unfortunately, if they're not in that case, then we do have to manage it by starting PAH therapy with the medications that we were briefly talking about earlier. Now, let's say we start the agent, and then the diagnosis for the PAH, the DTPAH, is FC2 to 4. Then we still have to start them on therapy too as well, because the disease has shown has got to a point where stop agent is not enough, and now we have to treat them from that end. So this is actually a list of medications so far that can cause PAH. The most noble ones, I would say, divided by definite association, which will absolutely cause it. It's possible, means that maybe not, but studies have shown that these can cause it. I will say here, like for the Minorex, the Benflorex, and the Dexpen, as well as the Chloroflu, those 4 agents up there are actually discontinued from the market. They're actually weight loss drugs. So those actually discontinued, so I don't even want to worry about that because I'm not going to see that in practice. Now, rapeseed oil, you might see it because some people do actually use rapeseed oil. And toxic rapeseed oil is mainly they're taking too much consumption of that. Methamphetamines, we all know that, I know the abuse potential for that, so that can actually lead to PAH as well. And then on the possible association right here too as well. This is where I would say for those that are going to the oncology, if I think are going to oncology, this oncology are going to more to the specialty side. These agents you see more so, and that's something we monitor for too as well, because they can lead to PAH if they're having those symptoms too as well. I think one thing that from a retail standpoint and community too as well that needs to be seen is that St. John's wort. Believe it or not, still occasionally still once a patient still using it for some reason. And among the other reasons why we want to use St. John's wort already, that's the reason why we don't want to use it for SI patients as well. But I will say though, for this slide here from you guys, from a non-based standpoint, my the questions I have for you guys, it wouldn't be I don't think I have a question for you guys on this here. No, I don't think I do. But I would say for the best way to take from this slide though is understanding that these medications can cause PAH and how we will manage it from that standpoint. All right, so now treatment guidelines for PAH. That will actually include our classification that we talked about earlier. So we'll start with the acute base of reactive positive. So the basic reactive test that I was mentioning, that's what we would do once a PAH diagnosis is made to see if they're a responder or a non-responder to calcium blocker. So that best response to calcium blocker therapy. And they are, we're good. That means now we can actually start calcium blocker therapy or CCBs. Y'all see here it says high dose, and we'll go in more detail about that. So that's what we use. And question you brought up earlier too as well on the agents. The ones that are being studied is the amlodipine, amphetamine, as well as the thiazide as well. Now, also too as well, our next section will be our treatment naive patients who have full FC1. These are your asymptomatic patients. There's thing but do have PAH as a diagnosis. We just monitor very closely at that point, and it will consider them based on what we see. Next, we have our FC2, or your true naive FC3 without the poor prognosis. FC3 is kind of is a big answer because FC3 depends on what their prognosis is. If they have a poor prognosis or no poor prognosis at that point. So that determines that too. So if they fall into that group, what we usually do, we can do a combination therapy, which you'll see more so on FC3 versus 2, because that's more progressive. And that Eversiten and tadalafil is like the study regimen that's been done, but you can interchange the classes within those same drugs. For example, instead of using tadalafil, I can use sildenafil in the case, and instead they'll still get the same result. Same thing goes with Eversiten. Instead of that one, I can use Bosentan instead. On that point too, but the combination wasn't studied, but studies show you can still switch the drug in that same class and still get the result. Monotherapy, which you see more so for FC2 being done, that will include like your Bosentan, your Macetan, your Eversiten, as well as your Sigwat, as well as sildenafil or tadalafil. I also want to add here too as well that your calcium blockers also can be used for monotherapy over these patients too. It's not in here, but that's also included too. And that's something I would know that. So with that too as well, on our next part will be our FC3 with evidence of poor prognosis. So these patients are also have FC3, but their chances are to hit more into the mortality category we're talking about. So these are patients who begin their parental therapy, which will be the continuous IV esabotril, as well as your continuous IV of the treprostinil or sub-Q infusion treprostinil. They also can use inhaled treprostinil in combination with a PDE5 inhibitor too as well, or a ERA, the endothelin receptor agonist too as well. So with that, I want to mention to like the generic medication here that wasn't on this chart, and that is Lexapac. That's actually that's an oral prostacyclin receptor agonist. So with that, that actually can be used for patients for class 2 to 3P without poor prognosis. So the way you do this way, you'll be in the same group of monotherapy for FC2 as well as FC3 without poor prognosis. And we have next our FC4, which these patients are pretty much on peripheral therapy. So remember, these patients are ones who they cannot move without having any type of symptoms, and they have signs of coronary right heart failure. So with those patients, they're definitely in the peripheral therapy that I just talked about, as well as this is wrong here. So on FC3, I did the wrong part. FC3 with poor prognosis, the treprostinil, the inhaled oral, that falls into FC3 with poor prognosis. But FC4, that's what I was talking about the combination with the inhaled treprostinil, with the combination with the PD5 inhibitors, as well as the ERA. So I'll make sure I clean that up real quick. Now, PAH patients with inadequate response to initial therapy, so alluding to what we talked about in the last slide, as we start adding there, because the there as well as adjustment of the dosage they're currently on if it's needed or it's warranted or it's possible. And then PAH patients with FC3 and 4 with adequate response to the maximal pharmacotherapy. At that point, these are the ones that we max out everything. We try our best with these patients. These are the end-stage patients too as well. So we start thinking about lung transplant as see if they're a candidate, and then we start thinking about palliative care because at this point, their chance of them passing away is very much so imminent on that end. Just imagine PH at that point. You guys have any questions about the slide? Good? Alright, cool. I asked because I want you guys to know this. That's why I want you guys to make sure y'all know it. Alright, cool.
So how do you make a question?
So pretty much it's actually just knowing there. Let's say example, if you have a patient who has FC2, know that warrior option how to treat this patient. So that will be a question I would have on there. So I actually have two questions on there. Now I think about it.
What's the other one?
Yeah. Okay, that got
Okay,
Linda. So with this slide, it's one we got because so when you're treating PH, you want to know what the FC number is. So if FC 1, 2, 3, or 4, because as you see here, that will dictate what regimen you should be thinking about for this patient. So added the fact of your calcium blockers, which I'm not here, but didn't have that down on your PowerPoint, that you can use between FC 1 to 3, 3 without poor prognosis, and Lexapac can be used for FC 2 or 3 without poor prognosis as well. Knowing those two things, and that's outside of this slide, and knowing this slide too, will help a lot. You guys good? Yes. Alright, cool. I'm trying to help you guys out here. Alright. Calcium blockers, or CCBs, these can be centered for all three types of PAH, which would be your IPH, your HPH, as well as your DTPH. None of these patients, this is an error check mark here. None of these patients must be positive for a vasoreactive test before starting therapy and a reevaluation every follow-up visit to ensure that there is a vasodilatory response there present. This is extremely important. And the reason why I say this is important, when I go to that dosage, you'll see what I'm talking about, is that with that pulmonary vasculature, in calcium blockers, we know that it does cause that vasodilation at that point. But if these patients being responders to it versus non-responders, responders are typically about 10-20% chance of responders. So if they respond to it with how the disease state is, you want to make sure you have everything up front to help them out with. And let's say this patient doesn't have a test result, and start capturing blood in this patient for that reason, for the doses that you targeted for them, you really want to make sure that test is on board because that can actually this can save patient's life at that point. Right? It's actually appropriate for them, and it helps slow down the disease state and help improve those symptoms, or it's not appropriate, and that can lead to those adverse effects that can actually put the patient 6 feet under too as well. So with that being said, a negative result from a vasoreactive test and starting a CCB on this patient for this particular reason at those targeted dosages can lead to severe hypotension, syncope, and RV failure, unless it's prescribed at a standard dose for other indications such as hypertension. So this is where I want to go a little bit and explain about this. So with calcium channel blocker poisoning or toxicity at that point, where a patient, if they had a mental health issue at that point, and they took their display amlodipine all at once, they're trying to take themselves out, for example. So what happens is, so now we're going to go back to, now we're going to photo level now. So you remember how your dihydropyridines, non-dihydropyridines, your dihydropyridines affect more the vasculature of the heart, while your non-dihydropyridines affect the myocardium, right? So, so your non-dihydropyridines being your diltiazem as well as your rapamycin versus your dihydropyridines dealing with amlodipine and amphetamine at that point. So so what happens is that with diltiazem and rapamycin, they call it that native entropy, which is causing the decreased conductivity, which can actually affect adversity for your heart failure patients at that point with using depression, because that'll actually get worse, worsen the symptoms, worsen the disease at that point. However, they don't have much function on their vasculature, so they do affect the blood pressure, not as much, because they're affecting more so the heart rate. While your dihydropyridines, which is your amlodipine and amphetamine, which are the two major medications in this class that we use for these patients, they're expecting their blood pressure not stable. They're just lowering our blood pressure in the hand. However, if we go to that concept of the receptors and saturation and how much medication the patient's getting, if they're getting too much of it, enough is enough for it to leak off from the vasculature and get into the myocardium and start causing the same type of effects as the diltiazem and rapamycin in that class, which can lead to that right ventricular failure at that point, because now you're affecting the cardiac output at that point, which is lowering that cardiac activity, and that's actually causing both of the ventricles to pretty much not work. So this is important to know that too as well, though. And I will say this, that most pharmacists don't really know about this because we never had to really think about that with the dosing for calcium blocker. We usually are pretty good at managing that. But in these patients, that's something we had to think about. But do you guys understand that process of how that works? Cool. So, know that your calcium blockers, like I mentioned earlier, can be used by the first line monotherapy in combination for FC1 to 3, which is 3 without poor prognosis. Know that once we know that the saturatory response is not achieved, or this clinical deterioration being seen while on that calcium blocker therapy, then despite having a positive test, we start checking it every follow-up visit, then we need to start adding other agents from different classes on board to help manage the patient. So coming back to that slide I was talking about earlier. Now, so let me ask you this. How many of you guys work in retail right now? I'm a little shy about that. Like, okay. So, all right. So for those of you out there right now, how often do you guys see amphetamine and given more than 60 milligrams twice a day on a prescription? Not that often? Okay. So in practice, you see more so in a hospital setting. You see a difference between ingredients to how to try to manage your hypertension, generally speaking, especially in end-stage renal patients. I give you an example. I actually had a physician of mine that I worked with over in the hospital. I think a week ago, matter of fact. Patient had end-stage renal disease. They were treated for hypertension at that point. They had no PAH at all. And they started the patient on 30 milligrams daily while in the hospital. And for the next 4 days, they were trying to send the patient home on 90 milligrams twice a day, which is actually targeted doses for amphetamine in regards to PAH. And what happened was that, for those guys, I'm not sure how many guys may know, but for amphetamine, the max dose for hypertension, the incident release, is 120 milligrams a day, or 60 milligrams twice a day. Now, what I explained to him, because he knew about the syncope standpoint, but he didn't know about the RV failure that could happen because the patient didn't have PAH to begin with. And when I explained that part, I was like, oh, shoot, I didn't know that. So that patient would actually random RP failure with them being on dialysis. That could push them more at risk due to what's going on with R2. We already know the fluid's been backed up, and we know how the function works from that standpoint. So the whole point I give that story is because that as pharmacists, right in a retail setting or in a hospital setting, I'm not a big fan of knowing the dosages for medication when it comes to teaching you guys. But in this area, it's extremely important for you guys, and so you gotta know for this, for your questions too, is because that in practice, I guarantee you, probably within the first, I'll put it further. During your rotation, you guys will run into it at some point. I guarantee you guys will run into it. It's like, oh yeah, I see him talking about that. We're talking about that. Yeah, I remember that now. I'm gonna fix that. That's my intervention right there. So this is very important to know this. So with that, know that all your target dosages are higher than the standard due to this disease state, because what's happening is that even though it's causing systemic vasodilation, we're trying to give enough medication to that patient where it leaks over to your pulmonary vasculature to create that vasodilation that we're looking for, since they're positive or a responder to their vasoreactive test. So we have to type it very, very slowly based on the response, because we're going high dosage here. And these patients actually usually have a blood pressure journal at home with specific holding parameters due to that reason. So that way we want to monitor the tolerability as well as the hypertension episodes they may experience. Because that will determine if they tolerate it or not, or they tolerate fine, we can start listening to dosage at that point. So like this, that's another part of pharmacists will be educating to is how to use that journal effectively, how to manage that standpoint, what to do and into as well. So amphetamine to release, starting dose is 30 milligrams once a day. The maximum tolerated dose per day, which is where we want to get it to, if we can, is 180 milligrams. Note that we do not use the immediate release formulas due to the risk of severe hypotension, because they work extremely fast, and that's a quick reservation to come back to the hospital when I raise it. If they would, let's say it was, actually give you an example. For those who are in retail, if you guys get that prescription coming in, and let's say you have family members come in and say, yeah, my mom got diagnosed with this thing called, I think, pulmonary artery hypertension, some of that, some pulmonary high blood pressure. There's a red flag say, hey, we're looking at this amphetamine prescription. So I'm looking at it first. Is it immediate release or is it extended release? If it's immediate release, that needs to be fixed. Because if they take it, this would be, lack of a better word, they won't make it. Because I'm just going to drop extremely fast at that point. And then the part to look at too is that dosage we talked about earlier too as well. So you see how we're seeing how from a real-time practice how this would actually affect you guys, not only as pharmacists, but also currently you guys work as interns too as well, where you're working at as well. So our next one is amlodipine. So amlodipine you tend to see more so because of the half-life that's pretty long. And the starting dose is 5 milligrams once a day. The maximum target dose per day, which we usually want to aim for them, to get their target response that we'll like for these patients, is 15 to 30 milligrams. And to put in perspective, max dose for amlodipine for hypertension, which you normally see being used for, is 10 milligrams a day. So you see what I'm talking about being high dose and how this can be a difference to that, knowing if that diagnosis is there or not. Next, you have diltiazem, extended release, or control release. Know that starting dose is 120 milligrams once a day. Know that your maximum tolerated dose per day, which you want to get for these patients, is 720 milligrams. It's still pretty high too as well. And just like we're talking about amphetamine, we do not use the immediate release diltiazem because it also raises severe hypotension as well. And actually the boot too as well. Also, this also brings hypertension and bradycardia. This is we're talking about myocardium from that standpoint with being a non-natural carrier. Go ahead. Any questions about the slide? So I want you guys to share another slide because that's something very important for you guys from a practice standpoint, and also for you guys questions as well. All right, now we have our ERAs, our endothelin receptor agonists. Our 3 drugs in this class will include aprocitentan, Ocitane and Macitane. Note how it works is that you have your endothelin 1, the ER1, that usually binds to both your ERA, which is endothelin receptor A, which leads to vasoconstriction of that pulmonary vasculature, those smooth muscle cells. And then the same ER1 also binds to your endothelin receptor B, which is ERB, which leads to vasodilation from the which would cover the nitric oxide and the prostacyclin production. Now, so ERAs, how they work is that they pretty much what they do is they block. They end up blocking that receptor for the ERA and B, so promote the vasodilation. Now your warning is okay. You're blocking A and B, but you're blocking B to help with dilation. But know that the receptor blocking potential for both for all the ERAs in this class, each one a little bit different, but they're all pretty much in the same group. That is the affinity is greater for ERA versus ERB. So you're blocking more so the ERA that deals with the vasoconstriction and deals going through the normal pathway, and you're not messing with the ERB because that's actually going to be helping. And an ERB really that's from a normal person standpoint. The ERA, ERB are just helping with hemodynamic standpoint is to maintain that process at that point. So as pH suggests, that's become dysregulated at that point. More so with the ERA, and that's why we target the ERA. That's in top of the fact we don't want to miss the ERB as much. Now, also want to say too as well that your ERAs, just like your calcium blockers as well, they improve exercise capacity as well as symptoms, as well as your functional class deterioration, and also slow down disease progression as well. Now, know the ERAs have teratogenic effects, and they should be avoided in pregnancy. Know that enrollment in a REMS program is required for all ages in this class. Do you guys know what a REMS program is by chance? Good deal. So all these patients, so if they're on any of these ages for the ERA class, they definitely be enrolled to a REMS program. Then we also have our nitrogen oxide, and our CGMP enhancers. Know that agents in this group, they do increase production of your NO as well as your CGMP, which leads to pulmonary artery vasodilation, and to a lesser extent, your systemic vasodilation. Know that it's accomplished by either stimulation of the SGC, which will increase the CGMP, which you want, and also increase the NO, which you also want, or it prevents the degradation of CGMP by blocking that PDE5 enzyme, as well as that way allows it to produce more CGMP to create that PA vasodilation that we want. So our PDE5 inhibitors, that will include only 2 medications in this class. That includes sildenafil, which is Rebasha, the brand name for that, and tadalafil, which is amilosertib. So, I will say, from the cost standpoint, we were talking about earlier, where your calcium blockers being the most affordable, your PDE5 inhibitor in this class will be the second most affordable, and then from there it just kind of drops out. Like everything's all very expensive. Now we also have your guanylyl cyclase stimulant, which is Restigouat. So that is also there's also used as well, and that requires a REMS as well too for enrollment. And know that this class also, as suggested earlier, with the ERAs and calcium blockers, they improve the exercise capacity, also improve symptoms, functional class deterioration as well, and slows down disease progression. Now, for our prostacyclin analogs and or prostacyclin receptor agonists, the agents in this group, they produce that potent PA vasodilation as as well as inhibiting that platelet aggregation too as well, and also have both cytoprotective and antiproliferative benefits. So I don't know if you guys remember when I was talking about the pathophysiology for PAH. Remember I was talking about different ways how the pulmonary artery can close up. So remember I was talking about how the cells can multiply at that point too as well. The thrombosis, or the damage to the pressure, and the artery can actually start closing up that artery walls as well. This is where the class can really help with that on that end. More so, definitely more so as we get more into our final class 3 with prognosis and 4 as well. So this actually comes by either stimulating your PR to increase the production of your prostacyclin, or increasing the amount of the PGI2 to your prostacyclin in this case, the body by mimicking endogenous prostacyclin. So we also have your oral prostacyclin receptor agonist, which is Lexapag. So remember I mentioned earlier Lexapag, on that chart we were talking about that wasn't on there. Remember that you can use it for class 2 and class 2 as well as for class 3 without proprognosis. Now, we also have your prostacyclin analogs, which will include your epoprostenol, which is a continuous IV drip. So it's a pump that the patient will be on pretty much their entire life at that point. As well, your treprostinil, which can give it through numerous different ways. You can give it as a continuous IV bag drip, like a pump, as well as a sub-Q drip too as well. You can give it as an inhaled dry powder or a solution through the vasal inhalation system, and also give it as tablets too as well. So with that, what I want to explain too is that the vasal inhalation system is pretty much a portable nebulized device that we use at home or outside. So they're very specially formulated just to give a specific dose based on what the patient will be getting. And so as Price suggests, it'll be pretty expensive too. Then we also have the iloprost. So your iloprost, that wasn't on that chart, but I want you guys to have in mind that the iloprost can be used for FC3 with or without poor prognosis, as well as for FC4. So that's something you guys should have that down there too as well. Now know that iloprost, it is given inhaled using the INEB ADD system. So the INEB the ADD system is similar to the Tabasco system as well, where it's pretty much like a battery-powered pulmonary drug delivery system, where it uses a mist, so that way it makes the patient take it in easier, and also they can use that anywhere they go. So they can use it at home, or they're at work, or wherever they're at that point. Now, probably next year I'll probably have pictures of those devices out here so you guys can see what it looks like. So now, as far as what they do from a business standpoint, so similar to what we talked about with ERAs and with our CGMP, enhancements to as well, and our capture blockers, they improve exercise capacity, symptoms, functional class deterioration, slow disease progression. But here's the thing I haven't line here that would be good for you guys to know, is that it does reduce mortality risk, but that only applies to epoprostenol and your IPA patients. So this is actually, so epoprostenol, which has to be what does the differential standpoint, is most patients are getting on this due to this reason. So if we find a patient, going back to the indications that we're talking about, if we find a patient has IPAH and it had to be FC4, now we know that we have to put on a parental agent. Epoprostenol is when you probably want to aim for first because there's a mortality benefit to it as well. So as long as they have IPAH, of course. So that's another thing. You know that too. All right. Did you guys have anemia lecture too?
Is that what
Anemia, y'all have one?
anemia?
Yes. What? Oh, no, okay. All right, good. I guess it was good too. I was supposed to call. So, sorry, I have a phone. So, okay. So, for anemia and iron status, patients for PAH, on the end, usually iron deficiency is 3 is pretty common. I want to say about, if we're talking numbers, at least 4% of these patients are usually iron deficient. So once a PAH diagnosis is made, we definitely got to screen them for the iron score to see if they're also anemic as well. Iron deficiency anemia. And the reason why it's so important because we got to screen them monthly for it, and it's associated with impaired myocardial function, as well as aggravated PAH symptoms and increased mortality risk. So there are areas pharmacists we got to jump into as well and make this well, which so a lot of times because usually your pulmonologists are generally ones who are, from a diagnosis standpoint, are dealing with these patients. And iron therapy is not so much of a forte. But for us, that is our forte. So that's something we had to keep an eye on too as well. Now know that for anemia, it's usually defined as a serum ferritin of less than 100, as well as transfer saturation or TSAT of less than 20%, as you guys are aware. Now for your PO iron, that's something that definitely is required if iron deficiency is confirmed. And that will actually add, so like with that, going into our IV iron infusion. So on this end, with iron infusion, it's only recommended if these patients are either have a hemoglobin less than 8, and or a patient can tolerate PO iron due at all due to the GI side effects. Now, like, let me ask you guys this question. As I mentioned here, hemoglobin less than 8. Why do you guys think we have that measure there for IV iron? Why not higher than that? Why not lower than that?
For the ferritin? For the ferritin, is that what you're asking?
So, like, so if hemoglobin less than 8, why do we want to use IV iron instead of why do we want to use IV iron instead of PO iron?
Because you wanted systemic circulation to get to the point first.
Circulation.
Yeah.
Okay. All right. So that's one reason, which I agree with. Anyone else?
I think doesn't it take longer?
So how many of you work in hospital right now? Okay. Have you guys hear about when we usually get blood transfusions? Market cutoff. So like when we get a blood transfusion in the hospital setting, of course we look at the hemoglobin and see if they qualify for that. Usually the hemoglobin is a 7. That's when we usually start giving PRBCs or a red blood cell transfusion at that point, blood in this case. Now we're going to say less than 8 because if it's less than 8, there are falls that are definitely in between at 7 and 8 at the very least, so we're trying to prevent them from having a blood transfusion. So that's why it's very important we use the IV iron pump because that PO iron will, as we know, it will take time for it to work. Now, first, IV iron will go right there immediately and start doing what it do. Because as you guys are aware when it comes to treating anemia, it's not a quick disease where it reverses quickly. It takes time. So if you can cut that time as much as you can, especially based on what the presentation the patient has, that's when IV iron will come into play. So with that, know that PO iron can be initiated if IV therapy has been completed if there's no prior GI tolerance. So for example, let's say we like you guys in your anemia lecture, y'all talk about how to calculate iron scores? Yeah. All right. So let's say, for example, they need about, maybe like let's make it simple. Let's say they need about 125 milligrams of iron. And we said, okay, so we're gonna do that. But their hemoglobin was also 7. So and they have never took PO iron before, so they don't have that prior GI tolerance issue. So it's okay. And let's say we need to go ahead and start treating it right now, so that way the iron can catch up and help with their hemoglobin as well and reversing anemia. So we get a one-time dose of, let's say, Prilosec, which is usually becomes as usually in hospitals, usually 125 milligrams for IV infusion, but we can also cut those in half, really. And maybe because we just want make sure the patient can tolerate it well, we're going to do half of it. So we do half of it, and then it's okay now. So we did half of it. We're going to do PO iron as an iron for them to keep taking at home, and they can follow with us within the next month or two, just to see how they tolerate and check their iron stores again on that point. So that's an something that can be done to these patients, which happens quite a bit, especially if cost is the issue. Because iron infusion, anytime infusion given outside the hospital, that's cost too. They're already spending a lot of money on their medication they take right now from a PAH standpoint, and their business as well, and the tests they have to do. And so now, as a pharmacist, you're thinking, okay, how can I save this patient money so when they can still keep their medication that they really take for their PAH? This is an option how you can go about that, as far as starting IV therapy first and go into your PO iron supplementation, which we know PO iron is pretty cheap. Now, note that it will take at least 2 weeks to see improvement in the hemoglobin as well. And also note that your ferritin and your T-sac will take at least 3 to 4 weeks for it to improve. Now, side effects and drug interactions. All right. Your CCBs, we have your hypertension as obviously a side effect as well. Orthostasis. Yeah, people know what orthostasis is by chance? Cool. So orthostasis is also a side effect we're saying, and you see that quite a bit in the hospital too. Generally speaking, for your calcium blockers, first, to give you guys a brief example, for me, where I work in methods like church care pharmacist, I actually work in an observation unit, so it's a short stay unit, where a short stay med surg unit, where basically you stay like average of maybe like 1 to 3 days, more so than 1 to 2 days really on that range. And if I had put a list of top 10 things patients come in into that unit, is due to sick leave. And with sick leave, we'll try to see, okay, let's get orthostasis done to see if they're positive or not. And that's important because if they're positive, then we know that we got to look at the medication scene. Mostly is due to medication induced, and your calcium blockers are usually on that list. So usually are we stopping that agent, or we adjusting the dose to that point, or switching something else completely different? That usually help manage that for as well. We also have your peripheral edema, which is dose dependent. Now, like let me ask you guys a question real quick. So with peripheral edema, can you use diuretics to manage that?
You said diuretics?
Yes.
Yes.
So show of hands, yes or no?
Yes.
Yeah.
So show of hands, no.
What's the trick?
Is that like half y'all don't want to answer? It was like, so
amlodipine can cause
Okay.
That's what you're saying, that's what's one of the causes for peripheral.
So with peripheral edema, so the answer to that question is actually a no.
Because you're using the amlodipine.
So this is a good way to talk about this too. I think we give you guys enough about this. Your calcium channel blockers, we know that peripheral edema, or more so that ankle, leg swelling that patients experience, that you can see in the arms too in some rare cases. That's so like the mechanism, or at least what we've seen so far with the study, is that what happens is that vasodilation, there's a capillary leakage that goes right at where that blood, where that volume, plasma volume in this case, is going outside the vasculature, but it's going into to your intestine, which is pretty much the outside of your cells at that point. So the reason why it's important enough for your calcium blockers, because that's our reach for your diuretics that will push the fluid out. So your diuretics, they're pushing the intravasculature, which is pretty much your veins, your arteries at that point. So when those vein arteries get congested at that point, then yes, you're pushing fluid out at that point, and it'll be receding able to get out, which we already know the urine on my hand. But while since for your calcium losses, that leakage goes in between your cells, it's very hard to reach that standpoint. So like actually a lot of reasons why you see a lot of polypharmacy, especially even with I've got cardiologists done this too, where they will try to put a patient on. I remember me a couple years ago. I remember I had a cardiologist that actually was trying to give him locating 20 milligrams a day for hypertension, and his thought was, oh, patient I can use hypertension, push the fluid out, help him out. But I explained that it's not gonna do any good for him because all you're really doing is putting a risk for adverse effects, and that patient was hyperkalemic due to that reason, he had to stop it. So that's another one you guys to be aware about that too. So if you guys see where patients getting low peak, for example, because I think calcium burns to get this little what's the best way to describe it? They get this safety net with these prescribers saying, oh, it's calcium blocker, it's safe, they won't have any issues. No, they can do this damage that any other class would, if not more. So if you see a patient who's getting amlodipine and you see them also getting hydrochlorothiazide or even getting furosemide or even diuretic, for example, and if you don't see an indication for a heart failure or you don't see anything that's required that is shows signs of hypervolemia in that patient, you may want to ask that question and say, hey, why are you taking this? At that point, they say, oh, this is my swelling from my amlodipine. That's when you go ahead and get that stopped at that point. Because it's not really helping that patient and you just put a rich parameters effects. And these patients got enough going on as it is. The last thing you want to do is actually want to put a diuretic on board to further compromise them on that end. So everybody understand that process? Alright, cool. So that being said, peripheral edema is more so happens with amlodipine and amphetamine. And also know that you see less so for diltiazem. So that being said, switching to diltiazem and or reducing the dose of amlodipine or amphetamine will reverse the edema as well. Know that when we talked about earlier about the myocardium on the standpoint, your dihydroperidines, and what has been seen so far, from a literature standpoint, know that both amphetamine and diltiazem are definitely not patients you want to use for a patient who has FREF, your heart failure with ejection fraction, because they will reduce the cardiac conductivity, which will lead to clinical deterioration. So that's like keep in mind if your patient has PAH and also has heart failure due to reduced ejection fraction, you will be aiming for amlodipine for these type of patients at this point because of that reason. Now, we also have our ERAs. First thing to look at is your hepatotoxicity. That's what we did doing it when we're trying to evaluate medication to start a patient on. We're demonstrating their liver function too to see how they're doing. So know that Bosutin has the highest risk for hepatotoxicity. Then your Mastatin is next, and your Eversitin is last. Now know that only Bosutin has the additional REMS monitoring requirement. So Bosutin is actually the only one that actually will have two requirements. Besides it being pathogenic, it also will have the hepatotoxicity as an area requirement of REMS. That's something you guys should know too as well. Right there for y'all. So now peripheral edema is also a side effect for your ERAs. You see it more so with Bosutin and Eversitin, and you see it at least with Mastatin. Now, I'll say this in this case. Back when we were talking about the peripheral edema and calcium blockers. Now, for them, these can be managed with diuretic appointment. You see more the peripheral edema is more so due to the vascular congestion in the endovascular space. So those you can use diuretics, but only if it's very mild cases. So if it's very mild, then you may do a diuretic. If they have to be hypertension, you may just do hydrochlorothiazide. measure blood pressure and get some fluid out at that point. I highly doubt you will see us use loop diuretics at that point because that'd be just way too aggressive on that end. But if it's more severe on that peripheral edema, then we're looking at just in that dosage that we talked about earlier, or change to a different drug in that class will have less likely to have those peripheral edema side effects on that end. Now, as we talked about earlier, ERAs are also carcinogenic, and the REST program is required, so that we can evaluate risk versus benefits for initiating therapy and monitor during therapy too. And know that ambrisentan has been shown to increase risk for pulmonary, for disease progression and for hospitalization for patients who have idiopathic pulmonary fibrosis. So this kind of goes back to the rationale of use at this point. So if they came in, let's say they had HPAH, which is the heritable PAH due to the genetic causes, but they also had pulmonary fibrosis, which is pretty random, but it does happen. Then I wouldn't use ambrisentan in this patient in this case if we had to use ERA for now, because of that risk of actually having increased hospitalizations. And it's also about disease progression, which we're trying not to do that. We're trying to slow down as much as possible, even halt it. Now, macitentan can cause nasopharyngitis, which is about 15%, so that's something to keep in mind too as well. Nasopharyngitis, I mean, with that, that's easily manageable. If that's what the patient is concerned with at that point, we can manage that OTC-wise. Right, that bacteria, of course. Right, now we have our NO, CGMP enhancers, so your PDE5 inhibitors, they can cause headaches, GI upset, flushing, muscle and joint pain as well. And we all know PDE5 inhibitors, they're conjugated with and combination therapy with nitrates of any kind. We know this that profound severe hypertension that it can cause on that point. So this is something to keep in mind too for those patients who actually have a history of instamy or instamy standpoint or unstable angina at that point, and there had to be anisotropic, for example. Those patients that may have to get switch to something else. We're going to start this patient on this type of agent because the blood pressure is going to drop and profoundly at that point too as well. Riociguat, the only side effect that's notable for them to be aware about is the syncope, which is important because syncope is also a symptom of the disease as well. So they definitely that's something to keep monitoring for too as well for these patients. Know that Riociguat also is a teratogenic, so that's why it's part of the REMS program work too. And know that a very rare side effect with Riociguat is that it will be your pulmonary hemorrhage. So if they feel the pulmonary hemorrhage, also you're going to start the agent to something else. Now we have your PO iron, which is no news for you guys. Cause GI upset, nausea, vomiting, abdominal pain. You also have constipation, dark colored stools, and then for that, how we manage that is actually, of course, take with food. They might be upset as well, but if we have to take it with food, what we should do, we do give them vitamin C at that point, and to take it with food at that point, since the food is going to decrease the absorption of it, and to maintain and optimize maintain that drug therapy at that point. Now, for that, on the PO iron, we still recommend vitamin C with it if it's in an empty stomach and to have those GI-related issues, because studies have shown it doesn't really help that much. But if they actually were to, if they were trying to take with food and we're trying to make sure they maintain compliance with this, that's fine. We'll also take with food, but also make sure with your food, make sure that it's vitamin C rich. So I'll say drink orange juice. Or they want to take vitamin C tablets, or they take a multivitamin. I just recommend actually get vitamin C and multivitamin too as well. Take it around the same time with it. Well, no, I want to take multivitamin because we had to keep separate. So I would say for that one, really just drink orange juice and keep it vitamin C rich for the food that you eat with it, and that will help with it. Now, also too as well, stool softener or bulk flowing laxatives will be important for these patients to help with either constipation, so to help optimize the compliance. IV iron, The ones you'll see is more so nausea, vomiting, as well as the abdominal pain as well. And the abdominal pain is more so prevalent. You see that with these iron infusions, especially depending on how high the dosage is as well. Also, and you'll know immediately because one of the patients gets that iron infusion. If they have a side effect to it, the first thing they will talk about is the abdominal pain because they describe it as having abdominal cramps. Which, if you think about what iron being, how that pure iron having those GI related effects, and no surprise that IV iron you will experience that pretty quickly. All right, so selection pack. So with that, side effects will be headaches, nausea, vomiting, diarrhea, joint and jaw pain. And we also have the ibuprofen and your treprostinil, the parental formulation. You know, the headache, jaw pain, diarrhea, flushing, hypotension, tachycardia, dizziness, as well as joint pain are all side effects. And believe it or not, these patients tend to experience at least one of these side effects at some point while being managed with these infusions. So there's a lot of titration involved with that too as well. And with that end too, that's why we also have to really be careful that they manage. And usually, our end from a pharmacy standpoint, we are really managing helping those drips to help them make sure it's in the right infusion and titrate it based upon the symptoms to us what they have to, while maintaining the efficacy for them, make sure that we're getting the best that need for them too. So with that being said, since it is parental, Phil, on that point. I'll say that it also leads to increased risk for thrombosis, as well as pulmonary malfunction, as well as infection due to the continuous use as a drip. And that includes also the subcutaneous drip for treprostinil too as well. Now, for treprostinil, both the PO tablets and as well as the inhalation as well, the flushing, nausea, vomiting, diarrhea, abdominal pain, as well as headaches, jaw pain, cough, as well as our throat irritation are all side effects you'll see with these with treprostinil through the PO route. Know that treprostinil is a very specific recognition for the tablets, where they have to take with a high-fat meal, which is a minimum of 250 calories, just to minimize the GI upset and increase the drug absorption. So that will be actually important for that patient when actually about the medication, if they were to get started for the PAH. And lastly, we have our L-Prost, which is the side effects such as this will be the pulmonary edema, syncope, headaches, flushing, as well as cough, as well as joint pain, hypotension, and nausea. So you see, I see you mentioned that the pulmonary edema. With that, we need something medication to get to experience the pulmonary edema that were developed during water on this medication, because obviously that's actually going to cause complications, which can push them right into that RV field, which is what we don't want for the patient. All right, that being said, what questions you guys got for me?
You have any questions on side effects?
I'm like, okay, that's a valid question. I was like, oh. But like, before I go into that, any questions about when it's went through together? Because like, even when it's when to look for it, you guys have to understand why you're looking at this. So do you guys have questions about the patho, how this works, as well as why we use these drugs, how we use them, and why we pick each patient? Alright, good. Alright, so that being said, I'm going to my big now on the question. I have 12 questions for you guys. So let's start with your question. Side effects, yes. Definitely know side effects slides at that point. So start with our text real quick. So the side effect slides definitely knows because I do have 3 questions about that. So, good question. So 1, 2, 3. I won't say 3 or 4. One's in the case and one's is a case question I have there that will relate to the treatment part here. Go there real quick. So right here, so when I was talking about that big hint to know this,
Yeah.
the case I have, this will help you. Along with what I mentioned about what can be used outside of facts. So the capture blockers are where it plays at, as well as selective fact too as well. That was something you guys need to know that part to help answer that question. And I do have another question that is a case, but well, it's not really a case. It's a short case question, but that does involve this slide too as well. I will say for you guys, for the case, I'll be familiar with the diagnostic process with PAH. I was only because it helped you guys answer the question. Because with it, the way the case flows, you kind of have you want to have a bit of understanding on why you're choosing that answer. Because if you just go on this slide by itself, you'll be like, use this, but I don't know why I would choose one over the other. I will say there is a question about the calcium blockers too as well. About that, especially with the basal active testing that I was talking about, and how we would manage therapy for them. So that's something that will be a question on that. I want to say it's on that same case. Now, this slide here where I was talking about the PA management and follow-up, as well as this slide right here, the pharmaceutical PH. Definitely know those slides because they'll put you in the framework to answer the questions I give you guys. So, like when I was giving you guys, example as a pharmacist, you're thinking about rationale, use, so it's appropriate from that end. Is it safe? Is it also cost effective at that standpoint that they can afford it on that end? And which will ultimately lead to compliance, will ultimately will actually benefit the patient. If you go out thought process mind and know how to adjust therapies as far as increasing dosage or change the frequency to make get more of the medication, based off efficacy standpoint, and also knowing to add a second, third agent, which this slide talks about too as well. That will be key to help answer those questions that I give you guys. Trying to see what else. DTPH, that's an area I want you guys to look into as well. The question I have you guys is not a case-based question, but it's more of a do you actually understand what DTPH and how we will briefly manage that. So this slide will be important. But I think yes. You guys didn't mark this slide down too, right?
Yeah.
Good. No, that slide too. That's slide. Like literally, if you understand this slide, it'll be clear to you by the time you look at the answer. You'll know that it'll be very obvious to you guys what the answer will be to that. Plus, as pharmacists, you guys should know this too as well. And I think as I'm talking, I'm just thinking about what else I'm missing. Oh yeah. I will say this: know this class knows what makes this class unique compared to the other classes as far as benefits. I'll leave it at that. And I think that's pretty much. Oh, this one too. So more so when you use PO versus IV iron. That's why I asked that question earlier. You guys actually remember why, and we had this have a discussion about that. That's why I asked. Well, all right. I think that is pretty much it. Enough one though. So I mean, and you guys got those on the slides too. The ones I pretty much underline or I put in for example, on that end. Those will be yes or no, but also something you can keep in mind when you look at the questions too as well. It's very important. I'll help you answer it too on that end. And yeah, that's pretty much it, you guys.
Thank you.
All right, you're welcome.